Okay, so today we will discuss about urodynamics. Urodynamics, definitely you get one EMQ question in exam and some SBAs also. And they expect you to know about what are the indication, when you will do it, how you will do it, and how you will interpret the graphs. So we know this well-known graphs of urodynamics, and this is really confusing sometimes because it is minute detail you have to understand and then choose the answer. So as we all know, knowledge is the only treasure that increase on sharing. I am very happy today to discuss urodynamics because this is something we need some help, some guidance to make the questions right. Same like CTGs, same like fetal genetics, the same like biostatistics, which all topics we think that we should discuss to get a better grasp on that topic. So let us start. So what are the lower urinary tract symptoms? Because urodynamics we are doing for lower urinary tract symptoms. What are they actually? They are classified into three categories. One, storage symptom. Second, voiding symptoms. And third, post-micturition symptom. So if you see what are the storage symptom, basically what all we are talking about, urodynamics, bladder diary, everything is about storage symptom. So in storage symptom, it comes the urgency, frequency, urge incontinence, stress urinary incontinence, mixed incontinence. These all part of storage symptom. It is the most common type of lower urinary tract symptom also. So that's why it become very important for us to understand it. And then second comes the voiding symptom. In voiding symptom, it will be about voiding. So it will be poor stream, hesitant stream, sometimes dribbling. That all will be the voiding symptom. Then the last comes the post-micturition symptom. So in post-micturition symptom, there will be incomplete bladder emptying, which you will get to know by residual urine measurement. Or sometimes there could be post-micturition dribbling. So these are the post-micturition symptom. So today we'll mainly focus on the storage symptom because that is the most common type of LUTs, and this is what we will talk about. So what are the incidences? If you see, the prevalence of women with at least one lower urinary tract symptom is 39% to 67%. So if you see, it is up to two-thirds of the women. Up to two-thirds of the women are at least suffering from one lower urinary tract symptom, which could be either urgency or frequency or nocturia, which could be anything. So this is really important because the prevalence is high. If you see the storage symptom, the most common will be the storage symptom in the LUTs. If you see the LUTs, the prevalence will increase with increasing age. This is also very important because as the age increase, the prevalence of lower urinary tract symptom increase. That's why in old age, gradually there are more urge incontinence, mixed incontinence, more difficulty with the age. So this is an important practical aspect we have to understand that the symptoms increase with age. Stress urinary incontinence is the most prevalent type of urinary incontinence. This is the SBA question for you. Which is the most common type of urinary incontinence? So the answer is stress urinary incontinence. In the study, they have seen incontinence study that it is up to 50%, then mixed is up to 36%, and then the urge is up to 16%. So it's very important for you to understand that up to two-thirds women are facing the problem, out of which storage symptoms are the most common, which is urge incontinence, stress incontinence, urgency, and frequency. It increases with age, and stress urinary incontinence is the most prevalent type of urinary incontinence. All of these are exam questions. All of this are asked in exam previously. So this is very important to remember. The other thing they ask you is, what is the incidence of urge incontinence in overactive bladder? So overactive bladder means urgency. Urgency associated with frequency, nocturia or other symptoms. And one third of the women will have urge incontinence. That is also an important aspect. And if you see, one third of the women with LUTs, their quality of life is affected. So these are all the questions they ask. So one third is a very important figure in urodynamics. And if you see, up to two-thirds are suffering from at least one lower urinary tract symptoms. Am I clear about how it is classified and how the percentage you have to remember and which all are the important percentage? Okay, great. Now, you have to understand the different terminology because in exam they will give you an option both overactive bladder as well as death pressure overactivity. So you have to understand what is the difference between these two. What is overactive bladder? It is a symptom. It is a woman's symptom. She will come to you and tell you that she is having urgency. Urgency is the defining factor for overactive bladder. She will come to you, she will tell you, I have urgency, I have frequency more than 8 times in a day, I have nocturia more than 2 times in a day. So that is a significant symptom. And then you will label her that she has overactive bladder according to her symptom. So this is a symptom-based diagnosis. It is defined by urgency with or without incontinence. As I told you, one third of overactive bladder women will have incontinence. So two-third will not have. So two-third will be dry overactive bladder and one-third will be wet overactive bladder. Usually, urgency will be associated with frequency and nocturia, and there shouldn't be any urinary tract infection or any other pathology. Because if that is there, you are not going to label it that it is overactive bladder. You will first treat that, and if her symptom doesn't improve, then only you will label her as overactive bladder. So symptoms are important, definition of urgency is important, and ruling out infection and other pathology is important to make your diagnosis of overactive bladder. And how detrusor overactivity is different from overactive bladder. If you want to know, detrusor overactivity is a urodynamic finding. So in urodynamic, you will see detrusor overactivity by involuntarily bladder contraction. Means the detrusor contraction you will see while filling. While ideally there shouldn't be any contraction of detrusor while filling. So filling detrusor contraction is something which is detrusor overactivity. And ultimately it will lead to urgency, frequency, nocturia, and urge leakage. So these two things you have to understand. One is clinical and one is urodynamic diagnosis. Now, what is the difference between stress urinary incontinence and urodynamic stress incontinence? This is also a common question. They will give you in question a scenario where the woman is leaking on increased intra-abdominal pressure. So if woman is leaking on coughing, sneezing, lifting heavy weight, anything increasing the abdominal pressure, then stress urinary incontinence is a clinical diagnosis. But when you are seeing it in urodynamics, when while doing urodynamics you are seeing that the woman is leaking while coughing, then it becomes urodynamic stress urinary incontinence. This is very important to understand that one is clinical and one is urodynamic. So if they give you in question only clinical thing, you will choose the option of stress urinary incontinence. And if they give you with urodynamic finding and which is supporting the diagnosis of stress urinary incontinence, then it becomes the urodynamic stress incontinence. So in that situation, you will not choose SUI, but you will choose urodynamic stress incontinence as your diagnosis once you have confirmed it with urodynamics. So this is how it is different. Now, these are all clinical things. Overactive bladder, a clinical diagnosis. Stress urinary incontinence, a clinical diagnosis. And mixed symptom. Mixed symptom means she has urgency frequency also as well as she's leaking while coughing or sneezing or increased abdominal pressure activity. Then if she has both the symptom, then she becomes the mixed symptom women, where you have to treat both the things, but you have to treat according to the predominant thing. So today we are not discussing about treatment. Definitely we'll do some session on treatment also. But in treatment, you have to focus first on the predominant symptom is what they usually ask you in the exam. Now, to understand how the systometry works, to understand how the urodynamic is done, first you have to understand what is the difference between filling and voiding phase. What is the physiology of micturition? So for physiology of micturition, if you see, in filling phase, detrusor muscle will be relaxed and urethral sphincter will be contracted so that it will be closed and the bladder will be filled. And the muscle is relaxed, so there will be no contraction in the detrusor and there will be no activity in the detrusor leading to any leak. And definitely urethral sphincter is closing it. So what is making this urethral sphincter to close is the sympathetic activity. So sympathetic activity is making the sphincter to close and detrusor muscle is relaxed while filling phase. So parasympathetic and the pons micturition center are not working. Only sympathetic activity closing the sphincter. This is about filling. Now, when it comes to voiding, the detrusor has to contract. So, when the proprioceptor in the bladder muscle, the pressure receptor, they will activate the parasympathetic activity. By parasympathetic activity, by the cholinergic activity, the muscle will contract with the permission of pons micturition center. So, if you remember, peeing, P, parasympathetic P, and pons micturition center P. So, all while peeing, all the P's are acting. Parasympathetic and pons micturition center are acting, while sympathetic now is relaxed. That's why the urethral sphincter is relaxed, and that's why while voiding, the women will be able to pass the urine. So this is how reciprocal contraction and relaxation of the detrusor muscle and sphincter will allow filling and voiding in the women. Am I clear about the physiology of micturition, how the different system works to allow the smooth filling and smooth voiding? Okay, excellent, Dr. Sadaf. Thank you. Now, how you will investigate a woman coming to you with lower urinary tract symptom. Very important for you to do the right investigation. What will be the first investigation is usually their question. So you have to understand that all our diagnosis depend upon that she shouldn't have urinary tract infection, because urinary tract infection can lead to symptoms of overactive bladder. It can lead to urgency, it can lead to frequency. So first of all, you have to do the urine analysis. Very important to rule out the infection first. The urine analysis is very important. And then the next investigation will be voiding diary. Can anybody tell me how long NICE recommend the voiding diary to be kept? How many days? Can you write it in the chat? How many days
Three
voiding
days.
diary? 3 days. Very good. So 3 days voiding diary you have to keep. In voiding diary, they say that you have to do it in the relaxed days, leisure days, as well as the working days, so that you get the real picture. So voiding diary is very important to be kept before doing any further investigation. You get to know about the pattern of the women taking drinks and voiding, both the things. This is important. Then if the woman has any voiding difficulties or she has recurrent urinary tract infection, then NICE recommend that you should measure post-void residual volume. So this is also an important aspect if the woman has any voiding difficulty. Then comes the urodynamic study. So there are certain indication to do urodynamics. You are not going to do urodynamics for all the women coming to you with lower urinary tract symptoms. So you have to understand the indication. You have to understand the prerequisites of urine analysis and voiding diary before doing the urodynamics. So this is how the bladder diary looks like. They give the women the bladder diary, which is like this chart where she will be filling up how much amount of liquid, the drink she's taking, at what time, what volume of urine she's passing, which she will measure, and how urgent it is. Was there any urgency? Was there any leak with urgency, which will tell you about urge incontinence? Was there any leak with activity like coughing, sneezing, lifting heavy weight, which will tell you about the stress urinary incontinence. And if she's using any pad, does she has to change the pad? This is how the bladder diary look like. This is more important from part 3 point of view, where they ask you the detail about bladder diary, as well as they ask you about the chart. Sometime in part 3 station, they will give you the urodynamics chart and they will tell you to explain it in the viva. So these are all practical aspect more important from part 3. But you have to understand that at least 3 days of bladder diary is required before going for any further investigation in patient of LUTS. This is also known as frequency volume chart. How much is the frequency? How much is the volume? So frequency volume chart is another name of bladder diary. So we have done the urine analysis, we have done the bladder diary. Now we want to investigate further. So we want to do the urodynamics. What is urodynamics? Urodynamics is all the measurements that will assess the function and dysfunction of the lower urinary tract by any method. So what does it include? It includes systometry and pressure flow studies. So what are the components? If you see, there will be physical assessment with uroflowmetry. First will be the uroflowmetry, which is a non-invasive test. The women will simply come and pass urine on the uroflowmeter and you do the uroflowmetry. Very important to do uroflowmetry and to do the post-void residual. Then comes the cystometry, which is the filling and voiding assessment. It is an invasive procedure because you will be putting the catheter, you will be filling the bladder. While this one, uroflowmetry is non-invasive. That's why first they do uroflowmetry and then next step is to do cystometry. And then comes the pressure flow study. So these are all the component of urodynamics. Now, what are the prerequisites? Very important to understand what are the prerequisites. You have to tell the women about the test. You have to inform her about what is urodynamic, why you are doing. You have to take her history, including her medication list. Why this is important? Can anybody tell me which are the medication which will similarly present like overactive bladder and like stress urinary incontinence? What are the medication? Can you tell me? Which medication behaves as if she has overactive bladder?
Antihypertensive,
Yes?
antihypertensive, alpha blockers, diuretics,
Antihypertensive, will it be overactive bladder or stress urinary incontinence? It is
stress.
stress urinary incontinence. Very good, my dear. What about the overactive bladder? Which are the drugs which will present as overactive bladder?
Any cholinergic drugs.
Very good. And what else? In practical purposes, if you see, if the woman is taking diuretics, if she's taking diuretics, definitely her bladder cannot handle it. So she will pass urine, she will have urgency, frequency, because diuretics is doing the diuresis, which is not normal. It is medication induced. Diuretics, sometimes sedative, like diazepam, like different sedatives that are also going to behave like an overactive bladder. Sometimes under the effect of sedative, they will not be able to control the urine. So sometimes in question they ask you that women is under these medications. So what it could present like? Will it present as overactive bladder? Will it present as stress urinary incontinence? Sometimes they will ask you reciprocally that stress urinary incontinence is caused by which drug? So you have to understand due to antihypertensive, alpha block. So this is very important to understand her medications because sometimes the medication will simulate the disease which is not there. So that's why history of medication is very important. Then, as I told you, prerequisite is you have to do urine analysis and bladder diary beforehand. So this should already be completed before going for the urodynamics. There should be a valid bother score and quality of life questioning. As I told you, 1/3 of the women quality of life is affected. And most of the time, women feel embarrassed to talk about the urinary problems. So that's why you have to talk to her. You have to allow her to open and tell you that how much this urinary symptoms are bothering her, how much it is affecting her quality of life. Then comes the physical assessment. You have to do the physical assessment because you want to rule out other pathology. You have ruled out urinary infection. You have seen the pattern of filling and voiding. Now you want to rule out any other pathology. What could be the pathologies which can present as overactive bladder or which can lead to other symptoms, which is not because of simply stress urinary incontinence or overactive bladder? So you have to do the abdominal examination, pelvic examination, assess for prolapse. You have to look for any masses because sometimes fibroid also will do pressure on the bladder and it will behave as overactive bladder. So it is not problem of bladder. It is the problem of fibroid, which is pressing on the bladder. So that's why you have to do the abdominal examination. You have to do the pelvic examination because prolapse sometime will present as overactive bladder. So rule out that things which could lead to the symptoms similar to overactive bladder and stress urinary incontinence without any pathology. So rule out the pathology, very important. Genital atrophy, very important because estrogen deficiency, vaginal atrophy sometimes will present as overactive bladder in old women. Can I ask you one thing? If there is vaginal thinning, if there is any vaginal atrophy and she is presenting with overactive bladder, what will be your treatment? Will it be systemic estrogen therapy or will it be local estrogen therapy, and why? If
Local
a woman,
estrogen therapy.
Local vaginal history.
why local? Why not systemic?
Because she
Because
has
it
a
will
neutral.
Yes, you all are correct that she has to take a topical estrogen, but why not systemic?
Because she has genital atrophy, and due to that reason she is having this problem. So atrophy will be improved with a local estrogen, and it will help her out in her symptoms.
Yes, you are right. That will improve. But if I give her systemic also, that is going to act there and it will improve. Yes, local is going to act better, but systemic can also act. Why not give systemic? Why it is contraindicated? Yes, atrophy will be treated by local.
Because
Correct.
it can cause endometrial cancer. It can cause endometrial cancer also, because it will alterate
Let
the
us not
endometrium
go
also
to
with the
the
estrogen.
cancers. We are not talking about the risk factor. We are talking about here urinary problems. If you see in study, they have found that systemic estrogen therapy can worsen the bladder symptoms. That's why. Because whenever you want to treat anything with the estrogen deficiency, you can give it either locally or systemically. But in cases of overactive bladder, never ever choose the systemic therapy because that can exacerbate her symptoms rather than relieve. That is the reason. That's why here the specific point that you have to treat it with local and systemic is contraindicated in such scenario. So this is a point. Now, you have to assess the muscle quality. This is important because in stress urinary incontinence, you are going to tell her to do pelvic floor muscle training, right? For 3 months, right? So you have to assess the muscle quality. How much is her muscle tone, pelvic muscle tone? That is that a reason of her stress urinary incontinence? And how much is the tone? Is it a weakness? So will the exercise going to help her? So that's why you have to assess the muscle contractility. You have to check for any leakage with straining. This is a clinical examination. And you have to do neurological examination if you are suspecting any abnormality neurologically. So these are all the things you will do before doing any urodynamics. Take her history, allow her to do these two things and do her thorough examination and rule out any other pathology. Now, how you will prepare her? Can I ask you, will you give her antibiotic for preparation before cystometry? Because that is an invasive test. You can introduce infection, right? So will you be giving her antibiotic, prophylactic antibiotic?
No,
Dr.
no,
Santosh
ma'am.
No.
say no.
Not
No. So you all know that there is no role of prophylactic antibiotic in cases of cystometry. Though it is an invasive test, but you are doing it in a clean atmosphere, you are doing it cleanly. So there is no need of prophylactic antibiotic. Now earlier there were recommendations that you have to stop the muscarinic drugs. But now the latest recommendation says that it is not necessary. Because if she's taking some drug, she's going to take it later also. That is for her health condition. So whatever symptoms she's getting, if that is because of that drug also, you want to check that how severe it is. So it is clinician decision. It is not 100% that you have to stop the muscarinic, which was the norm earlier. So the latest recommendation says that it is your choice if you want to stop the muscarinic or not. Then you have to do the urine dipsticks to check for infection or hematuria. This is important because if there is infection, you will abandon the procedure and you will give her antibiotic. So you will do the urine dipstick to check for the nitrite, to check for the leukocytes, and to check for the red blood cells, which is hematuria, which is important. Then you have to reduce the prolapse. How you will reduce? Either you will use pessary, you will use speculum, or by finger. Somehow you have to reduce the prolapse because prolapse is going to produce the symptom of overactive bladder. So you don't want the false impression because of prolapse. You want to know about her bladder. You don't want to know about other pathology causing this problem. So thank you, my dear Sadia. Thank you so much. So prolapse to be reduced is really, really important in the preparation. So these are the true prerequisites. Do the urine dipstick, rule out infection, and reduce the prolapse before going for the urodynamic study. Now, what are the indications? In exam, they ask you the question that she has undergone the stress urinary incontinence surgery. Now it has failed. So what will be your next step? So what you will choose? This is a common recall and famous and recent recall. So what you will
MDT.
do? If she has a failed surgery of
MDT.
stress urinary incontinence, what will be your next step?
Urodynamic
MDT.
study.
Repeat Urodynamics.
Urodynamic
Repeat
study. Very good.
Urodynamics.
We will do
Yes.
urodynamic study because NICE doesn't recommend urodynamic study before pure stress urinary incontinence, before doing surgery for that. But whenever there is failed surgery, you have to do the urodynamics. That is the important aspect you have to understand. So if you see NICE recommendation for urge incontinence before surgical treatment. So what is the surgical treatment for urge incontinence? Anybody?
That is actually the botulinum toxins
Yes, very
has
good.
been given to the
Very good, my dear. So botulinum toxin A, Botox, yes. Botulinum toxin A. Please remember A because sometimes they will give you B to confuse you. So botulinum toxin A insertion when you do in the bladder under your cystoscopy guidance, that is the surgical management of urge incontinence, which you will be doing always after MDT. So whenever they ask you stepwise approach, before any surgical treatment, you have to choose MDT referral. So in options, if you have MDT referral, you have to choose that. So before surgical treatment, always in urge incontinence, you have to do the urodynamics to make sure that this is urge incontinence. In cases of stress urinary incontinence, we saw that in pure SUI, NICE doesn't recommend to do it, but you have to do it if there is voiding dysfunction, there is anterior compartment prolapse, or there is previous surgical management. This is very important to understand. Somebody's mic is on. If you can please switch off your mic. Okay, thank you. So if you see in SUI, if they give you in the question that women have symptom of SUI like leaking with cough or anything, and she has voiding dysfunction, they will say that she will have poor stream or she's having difficulty in passing urine, some voiding symptom they will give you. Or if they give you SUI symptom with prolapse, or if they give you previous surgery. In all this scenario, you are not going to do surgery before doing the urodynamics. So the next step will be in such women will be urodynamics before the surgery and definitely MDT referral. So this important 3 points you have to understand that when you have to choose in the option urodynamics as the next step before doing the surgery. Am I clear about this? That when you will choose urodynamics in SUI? Okay, great. Now, what about the video urodynamics, ambulatory urodynamics? All this you have to understand that this is not part of our core curriculum. This is not for ST3 to ST5. This is not for MRCOG Part 2 candidates. So don't worry about this. These all video urodynamics, ambulatory urodynamics, they will not ask you the detail. They might ask you that when you don't get any answer from the urodynamics, what will be your next step? So in that case, you will choose video or new ambulatory urodynamics, but you don't have to know the details of that. So to know when to do urodynamics according to NICE is enough for you. So for urge, anything before surgery, and for stress urinary incontinence, in these 3 scenarios, you will be doing the urodynamics. So anytime when there is failed conservative management, the next step will be urodynamics, like bladder retraining in urge incontinence for 6 weeks and pelvic floor muscle exercise in SUI for 3 months. Next step will be the further MDT referral and testing. Now, this is the urodynamic setting. If you see, urodynamic is also known as multi-channel filling and voiding systometry. Multi-channel because there are 3 channels. Filling and voiding because we are checking both things. Systometry, we are checking about the bladder. If you see here, this is for filling. There will be in the bladder, there will be 2 catheters. One for filling and one for, this is for filling tubing. And this is the catheter for pressure measurement. Now, this is the another catheter which will be in the rectum. Or sometimes if you cannot put it in the rectum, you can put it in vagina to measure the abdominal pressure. So bladder pressure, abdominal pressure, and filling catheter. These 3 will be the channel in the bladder. This is a computer which will monitor, which is connected here, and it will monitor the pressure, and the graph will be shown in the computer for you to interpret. This is how the urodynamics are done. This is the urodynamic chair, and the woman is comfortably sitting, and this is the uroflow meter, where first the women will pass the urine and then you will be doing the artificial filling of the bladder to recreate her symptom, what the women usually is facing. That symptom you want to recreate, so you are filling her bladder under your vision and you are checking what is happening in her bladder while that filling, while voiding. What is happening in the bladder? What are the pressures? Is it normal? Is it abnormal? So this is how the urodynamic setting is. Now, as I told you, uroflowmetry is a non-invasive thing. What she has to do is simply void by relaxing, not straining, and sitting on a commode over a rotating disc flow meter. So this is what the women will do, and 3 measurements you will take will be the volume of urine passed per unit time, which will tell you the flow rate, milliliter per second, flow rate. It will give you the maximum flow rate, the amount of volume voided you will get, which should be at least 200 ml to judge in the uroflowmetry. At least 200 ml the women should void. Then only you can get the right flow rate. Then you will measure her residual volume, which can be done either ultrasonically or with the catheter. Because catheter is invasive, you can go for ultrasound. But whenever you find a significant residual urine, then you have to reconfirm it with the catheter. So this is how it goes. So if you see, this is the uroflow meter. Woman is sitting and without any strain, relaxed, she's passing the urine and you are measuring the amount of urine as well as you are measuring the flow rate. These 2 things you will get. Women will be relaxed, she will void in privacy, she shouldn't strain because that will affect your reading. and you should at least get 200 ml of urine so that you can understand the right thing. And here you will measure the amount. This is the volume, and this is the Qmax, which is the flow rate. This is what you are recording by the flow meter. You have to understand the normal urodynamic parameter. Believe me, if you remember this, half of the question you can solve just by understanding what is normal and what is not normal. Because if you know the normal value, you can easily detect what is abnormal, and easily you can make the diagnosis of overactive bladder. So very important for you to understand that the normal bladder capacity is 400 to 600 ml. So anything less than 400 means you will think that her bladder could be overactive. First desire to void is from 150 to 200 ml. So anything less than 150 means she could be overactive bladder. So this is important to remember. Detrusor pressure while filling. Very important that it should be less than 15 centimeter of water. Somewhere it will be written less than 10. There are variable things in different, according to different society. But in TOG, it has been given less than 15. So for us in exam, you have to remember less than 15 centimeter of water while filling detrusor pressure, because we are not expecting detrusor to contract while filling. We want it to be relaxed. The pressure should be less. So the pressure should be less than 15 centimeter of water. Now while voiding, you want the detrusor to contract, to void, right? So the pressure will increase. We want it to increase, but it shouldn't go beyond 70. If it goes beyond 70, it suggests that the woman is voiding against obstruction. So extra pressure. If it is up to 70, you are happy that it is in your range. But if it is more than 70, then you understand that it is voiding against the resistance. It is voiding against the obstruction. So this is important. Peak flow rate more than 15 ml per second is what you want. Qmax, if you see, 25 ml per second, and in the TOG it is given 20 to 36. So anything up to 36, you will take the Qmax as normal. So this range is very important. Flow time will be 15 to 30 seconds. Means she will take only 15 to 30 seconds to void. Complete voiding will finish in 15 to 30 seconds. So flow time is also very important. If she's taking longer time to flow means she's voiding against obstruction. Could be prolapse, it could be stricture, it could be because of your continence surgery, anything. So flow time is important. Flow rate is important. If the flow rate is less, means against, she is voiding against obstruction. Qmax, the normal value you have to memorize it, because any question, they will definitely give you Qmax, capacity, and first desire to void. These three will definitely be there. You should know what is normal in this scenario. Residual volume, earlier they used to say less than 50, but in recent talk it has come less than 100. So anything less than 100, you will consider it normal. So if they give you 80 or 90, don't think that residual volume is more. Anything less than 100 is normal. I cannot emphasize enough that this normal urodynamic parameter, if you don't remember, you cannot solve any question of urodynamics. So this has to be learned by heart. This has to be on your brain, your tip of finger, that what are the normal values to understand what is abnormal. Am I clear about normal parameters? Anybody has any doubt about it? Okay, great. So all of you, please remember this, memorize this, and half of the job is done if you remember. Now, in uroflowmetry, if you see, this is a bell-shaped curve. This is the usual curve of uroflowmetry. It is bell-shaped curve. If you see, this is the Qmax. If you see 24, more than 24 almost. So somewhere 25 to 28 is the Qmax for this women. So this is the maximum flow, Qmax, bell-shaped curve, which is normal. And the volume, if you see, this is the volume, 250 ml is the volume, and we wanted more than 200 ml. So this is a valid uroflowmetry because our volume is more than 200, and this is a normal uroflowmetry because the curve is bell-shaped, and Q max is 25 to 28, and our normal range is 20 to 36. So we are happy about it. So this is normal. Flow rate, this is the flow rate and this is the flow time. So this is telling you about the time. This is telling you about volume. So this is how you will calculate from the uroflowmetry everything about flow rate, volume, maximum Q max, and flow time. This all information you will get by uroflowmetry. Now, how you will interpret it? What is a normal uroflowmetry? What is abnormal? So these two are abnormal. So why you are getting these abnormal things? We have to understand that. Why there is several peaks? Why there is several peaks in Q max? Here you are seeing not a bell-shaped curve, but a several peak curve. Why it is coming? It is coming when there is bladder outflow obstruction or when there is unsustained detrusor contraction. Either outside obstruction, which is not allowing the urine to flow smoothly, or inside dysfunction of the contraction, which is not allowing the urine to pass smoothly. So that's why you are getting multiple peaks. If you see a multiple peaks, you have to choose in the option. Either it is outflow obstruction, which could be anything, which could be prolapse, which could be stricture, which could be anything, or there could be abnormality in the contraction. So there will be several peaks like this. Now reduce Qmax. Reduce Qmax means the Qmax is reduced and plateaued. Here you are seeing the Qmax is reduced. Ideally it should be up till here. It should be more than 15. If it is 7 or 8 like this, though the parameter not given here, but this low means it is half of the depth, so it is 7 or 8. So if that is the Qmax, you are unhappy. So why it has happened? Why the Qmax is reduced? Again, when the woman is voiding against the obstruction. So what could be the reason? Again, urethral stricture, external compression due to prolapse, which will lead to kinking of urethra, or following continence surgery, or failure of bladder neck relaxation. And again, the contractile detrusor. So either outside obstruction or inside abnormality in the contraction ultimately can lead to either multiple peaks or can lead to a plateaued graph. So this is how sometimes they will give you a plateaued graph and they will ask you what it could be. So if they give you stricture, you will choose the stricture. This is how they formulate the question from uroflowmetry. They will give you a graph of uroflowmetry and ask you the diagnosis, and they will give you the hint of how to rule out other things and how to choose that particular diagnosis. Very high Qmax you will see in cases of, again, detrusor overactivity. And if the detrusor is trying to overcome an obstruction, it will behave overactively and you will get very much peaked Qmax, which is above normal. The normal is up to 36. So if you get more than 36, that means the detrusor is doing overactivity. So this is how they ask you about the uroflowmetry graphs and the diagnosis. You should know the normal uroflowmetry, how it looks like bell-shaped, amount at least 200 ml, normal Qmax. These all things you remember, then only you will be able to detect the abnormal uroflowmetry and the graphs. Now, systometry. Systometry, now we are testing the bladder. Uroflowmetry, we have not done any invasive thing. We have just told the women to sit on the commode, which has a uroflowmeter, and she has passed the urine relaxedly, and we have measured. Now, in systometry, as I told you, that it will be a multi-channel filling and voiding systometry. So we will be checking bladder storage abilities as well as voiding. Is it normal or abnormal? So what you will do, you will create a situation where she developed the symptom. So you will artificially fill the bladder. You will fill the bladder and measure the pressure. So how you will fill the bladder? As you see here, you will fill the bladder to the catheter and then you will measure the pressure. Pves will be the vesicular or bladder pressure, Pdet is the detrusor pressure, and P abdomen is the abdominal pressure, which you will measure by either the rectal or vaginal catheter. So if you know the P abdomen and P ves, you can calculate the P detrusor. The system is going to calculate the P detrusor by deducting abdominal pressure from the vesicular pressure. This is very important. This is very important to understand that how P detrusor comes. If you see, the abdominal cavity pressure is P abdominal, bladder pressure is P vesical, and P detrusor is P vesical minus P abdomen. So it is calculated. So it depends, P detrusor depend on these two pressure. This comes by deduction of abdomen from the vesicle. So remember that P vesicle is the biggest one. And from that you have to deduct the abdominal pressure to get the detrusor pressure. Now if you see what is the normal value, so P vesicle, the normal value will be 5 to 50 centimeter of water, and P abdominal also the normal value will be 5 to 50. And P detrusor, which is P vesicle minus P abdominal, normal value is 5 to 15. Up to 15 is normal. Anything more than 15 is detrusor overactive. So please remember this 15, very, very important. And the upper value for this is 50. So this is how systometry is done, filling and voiding systometry. Usually in graph, they will give you both. Sometimes they will give you only filling, and sometimes they will give you both the filling systometry as well as the voiding systometry. So how it is done, as I told you, all the catheter will be put and then the filling will be done. Usually it is done by 50 ml per minute, but it can be done at the lower volume if the women bladder capacity is low. So they say up to 10% of women bladder capacity, with that you have to start. Catheter will be put, then the women will be told to cuff. You tell to cuff because you want to check that it is placed properly and it is working properly. So every now and then you will tell the women to cuff to check that P vesical and P abdominal are increasing and P detrusor is not increasing. That means if while cuffing P vesical and P abdominal is increasing, means your catheter are in place and it is working. So that is how you check that your catheters are placed properly and it is working well. So you will every now and then you will tell the women to cuff to check that your catheters are measuring. So after the filling, you will tell the women, you will recreate the situation like tap of water running or putting her hand into the cold water to create all her symptoms which are giving her trouble, which are giving her urgency or incontinence. You will tell her to cough to detect the stress urinary incontinence. So this is how you will create the situation and measure the outcomes in the systometry. So you have to understand some simple things like first sensation of bladder filling. First sensation, very important. FS, first sensation. FD, first desire. SD, strong desire. Because in systometry, in the graph, if you see, it will be written cuff, cuff to check that it is working well. Cuff, cuff, cuff to check that it is working well, and both are only simultaneously increasing. Then first desire. FD, first desire. ND, normal desire. SD, strong desire. Cuff, 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 cuff. So constantly you are telling her to cuff to see that the catheters are working, it is measuring. First desire, very important. If you see here, it is coming at the level of around 250 ml. And our first desire, we want between 150 to 200. So 250 is a good. That means her first desire is my dear, if you can please close your mic. My dear, if you can please close the mic. Rehana?
Sorry, Dr. Shri.
No problem, my dear.
There is some problem. I think there is some problem.
Okay. So first desire, very important. First desire, if you see here, it is 250. This is a volume. This is the start of filling. You are filling. And here is the first desire coming. So it is 250 ml, which is normal for us. Anything between 150 to 200 is normal for us. Then comes the normal desire. Again, the normal desire, if you see at the same time, she's feeling the normal desire, it's okay. Then comes the strong desire. This is the strong desire. If you see, the strong desire is coming above 250, which is also okay. Then the maximum systometric capacity. It is coming up to 500. So that is also normal. So if you see, this is a normal systometry because all our volumes are coming normal and we are not seeing any detrusor contraction. So the detrusor is relaxed while filling and we are only seeing while cuffing the abdominal and vesical pressure rising, which we are expecting. So it is a normal systometry. Here is the voiding, this is filling, and this is voiding. In voiding, if you see, this is the volume and this is a bell-shaped curve. So we are happy. The voiding is also normal. And if you see the Q max, it is 24, more than 24, somewhere less than 36. And we know that up to 36, we are going to accept it. So this is Q max is normal. If you see the volume, it is quite a lot. So it is normal. So that means this is a normal systometry, normal filling, normal voiding. In exam, they give you this. And believe me, online nowadays exam, so they can give you any chart. And sometimes by seeing it itself, you don't understand what to see, what not to see. Because we don't know all this terminology. We don't know what the CG means. We don't know what is FD, ND, SD means. What is MCC? So very important for us to understand this. This is filling part and this is voiding part. And in voiding, you are expecting the detrusor to contract. So this is good. This is normal. While here you want the detrusor to be relaxed and it is relaxed. PVS, it is relaxed. So, sorry, PDET, it is relaxed. So we are happy. So this is how if you see in a graphical form, the filling phase and voiding phase, you keep telling women to cuff to check if it is working well. And while voiding, she shouldn't have any abdominal straining. While voiding, you will see that P vesicle and P detrusor is rising. Now here they have given the Q max of 40 to 60, but don't consider that because as I told you, there will be different values by different continent society, but you have to take it up to 36 normal. Qmax up to 36, you will take normal, right? And the detrusor pressure up to 70, you will take the normal. So here it is 40 to 60, so that is normal. Now here if you see P West, we want less than 50, so it is normal. P abdomen less than 50, so it is normal. So while filling, there is no detrusor contraction, but while voiding, there will be vesicle and detrusor contraction, and there will be flow. So this is voiding, and this is filling, and detrusor pressure you want less than 15. So this is how the uroflowmetry is judged. Now, how you will interpret urodynamics? When you will tell that it is stress, when you will tell that it is detrusor overactivity. Very important. So you have to see the graph. While seeing the graph, first of all, you have to see the P detrusor. Very important to see the detrusor. If the detrusor is rising and vesicle is rising, means these two are coinciding and there is leak. So it is detrusor overactivity because in filling we didn't want any detrusor contraction. This is the filling systometry. You are seeing that detrusor is contracting, so it is not good, as well as it is leaking. So this is detrusor overactivity with leak, with incontinence. You have to understand that sometimes there will be detrusor overactivity but no leak. In that situation, you will choose the option of detrusor overactivity without incontinence. But if there is a leak, this is a leak, you will choose detrusor overactivity with incontinence. This is very important to understand that there are two things. All detrusor overactivity are not going to lead to leak. So understand these two scenarios. Then the other scenario you have to understand is that detrusor overactivity could be unprovoked without doing anything, or could be provoked. Provoked means if you are running the tap water, if you are putting your hand in the cold water, that is provoked. Or while coughing, that is provoked. But without doing anything, if you are seeing detrusor overactivity, that is unprovoked. So these two terms also you have to understand. So whenever you see a detrusor overactivity, there is possibility that it could be with or without incontinence. There is possibility it could be unprovoked or provoked. That is important. So if you are seeing the wave in vesicle and detrusor, means it is detrusor problem. You don't like it, right? While in cases of stress incontinence, you will see vesicle pressure rising, abdominal pressure rising, and there is no detrusor activity. As I told you, first see the detrusor. If detrusor is overactivity, your answer always is detrusor overactivity. If detrusor has no activity, then you have to see if two these are rising, then it is stress incontinence. While cough, if she's leaking, this is stress urinary incontinence. But in this same scenario, if I would have got the detrusor overactivity also, what will be my answer? Anyone?
Mixed, mixed,
No,
mixed urinary incontinence.
no. If you are seeing detrusor overactivity while coughing and leak, it is cough related detrusor overactivity. So ultimately it is provoked detrusor overactivity. You have to label stress urinary incontinence only when there is no detrusor overactivity. You get my point or not? Because this is very important. If any time you have detrusor overactivity while coughing and leaking, it doesn't become stress incontinence. It becomes provoked detrusor overactivity, leading to a leak. So to diagnose stress incontinence, there shouldn't be any detrusor overactivity. Because whenever there is detrusor overactivity, it is not stress incontinence. Then the diagnosis goes to detrusor. Then the detrusor is blamed for it. Am I clear about this? That is what provoked detrusor overactivity. To diagnose stress, there shouldn't be any detrusor activity in the graph. That is a mandatory factor. To diagnose stress incontinence, no detrusor overactivity. If there is cough with detrusor overactivity with leak, it is provoked detrusor overactivity. It is not stress. Am I clear about this point? That's why I told you that look for the detrusor first. If detrusor has any activity, always your diagnosis is detrusor overactivity. Irrespective of is it because of cough, is it because of running water, or anything. So detrusor pressure is the first thing to notice to make your diagnosis. And if that is not absent, and you are seeing these two rising, then you will make your diagnosis of stress. It is rising anytime. It is always detrusor either provoked, either unprovoked, or with continence or without continence. Clear? All of you clear how you'll interpret?
Then how will you say about the mixed incontinence if it is
Mixed incontinence
detrusor
means,
overactivity?
we will come to the graph for mixed incontinence. Mixed incontinence means in the graph, you will see these two rise and there is no detrusor overactivity and leak. And in another portion, you will see these two rise and with overactivity and leak. So one time you have seen without detrusor overactivity leak, and one time you have seen with overactivity leak. So that means it is mixed. You should see both the pattern in one filling systometry to make it mixed. Clear? What one with detrusor overactivity and one without detrusor overactivity. I do have that graph in the questions. You will get to know about how it look like. Clear, my dear?
Yes.
Once we see the application of all these graphs in the question, you will get more clarity. Now I'm giving you an overview Now I am giving you an idea. Don't to get afraid of what is this FD, ND, SD, MCC. Now you all know the full form of this, so you can understand. Now, if you see this one here, this is the vesical pressure which is rising, and this is the detrusor pressure which is rising, and abdominal pressure no rising. So it is rising of detrusor, rising of vesicle, and there is leak. This is the leak. So see, this small minute thing also you have to notice, because if it is not there, I will label it as detrusor overactivity, and if the small leak is there, I will label it as with incontinence. So the small leak below in the ml per second you have to notice, very important. So the graph is very minute, and you have to understand any minute changes is significant. So here abdominal is not changing, only detrusor and vesicle is changing with a leak, so it becomes detrusor overactivity with incontinence. Am I clear about this?
Yes.
Okay.
So, Dr. Shweta, in the previous graph that you showed to this, the one, yeah, this one. So this P Ves, P abd, and P det, all three will not rise together at any time, right?
It will rise in cases of provoked detrusor overactivity. In cases of
All three will
provoked
rise.
detrusor overactivity, you will see all three rising. Then only you are labeling it as detrusor overactivity, because whenever P det is rising, it is always detrusor overactivity. To label it stress incontinence, it shouldn't rise.
Oh, yes, yes. Okay.
So all three can rise. You're
Thank you.
perfectly all right. You're saying it very correctly that if all three rise, your diagnosis will be detrusor overactivity, provoked detrusor overactivity, because of cuff.
Okay.
Cuff provoked detrusor overactivity, where all three will rise. Clear?
Yes. Thank you.
My pleasure. Now, this we already saw. This is normal. This is normal filling and normal voiding systometry. Now, this one, if you see, again, cuff, 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 first desire, strong desire, maximum systometric capacity, strong desire, cuff, cuff, voiding. Now here, if you see, there is contraction in the vesicle, there is contraction in the detrusor, and there is no activity in the abdomen. As I told you, first check the detrusor. You check the detrusor, you find detrusor activity, means what will be your diagnosis?
Detrusor overactivity.
Yes, very good.
So
Now, if the same thing would have been with cuff, here I will write CG, and you see the rise. What will be your diagnosis?
Stress incontinence.
overactivity. Provoked.
Provoked detrusor overactivity.
Provoked
This is what I'm trying to tell you all, because this is really, I can understand this is difficult, but you have to understand that anytime if you are seeing detrusor overactivity, your diagnosis is always detrusor overactivity. Never make it stress. For stress to diagnose, there shouldn't be any detrusor activity. That is mandatory definition, which I will show you in further slide. So see first the detrusor and make your diagnosis. If detrusor overactivity, the diagnosis always is detrusor overactivity, either provoked or unprovoked, either with incontinence or without incontinence. Now, if you see here in voiding, vesicle is rising, detrusor is rising, abdomen not rising, because you don't want any abdominal strain while voiding. So this is a normal graph for voiding, and this is the volume passed. If you see the maximum Qmax here, it is going up to 12. If you see the volume passed here, it is going less than 250. You're seeing it? It is somewhere around 175 to 200. So this is detrusor overactivity. Clear? Now clear to you by the graph? See the P det first and then make your diagnosis. This is the key point. Now, if you see detrusor feature, what all you want to see, how is the compliance? Because compliance means detrusor pressure. How much the detrusor pressure is rising, how much the vesicle, sorry, not the detrusor pressure, vesicle pressure is rising with change in the amount of fluid. If it is less than 30 ml leading to 1 centimeter change, means it is low compliance. If more than 100 ml leading to 1 centimeter change, means it is high compliance. Ideally, it should be somewhere 40 around. So if with 40 ml or so it is changing 1 centimeter, you are happy. But less than 30 ml changing to 1 centimeter, bad. That means low compliance. And more than 100 is changing, means it is high compliance. So low compliance seen in post-radiotherapy, high compliance seen in neurological causes. Capacity will be up to 1 liter. Ideally, it should be around 500 to 600. So high compliance, because the nerve is not sensing how much it is filling. That's why it is going up to 1 liter. So that is high detrusor compliance. So sometimes they can ask you about the compliance. What is low compliance? What is the reason? What is high compliance? And what is the reason? Then comes the detrusor overactivity. It is involuntary detrusor contraction we saw during filling phase. It can be spontaneous and provoked, I told you, and the amplitude should be more than 15. I told you that not all detrusor contraction will lead to symptom. So it might be clinically significant, it might be not. The urgency will always be there before the leak if it is because of detrusor overactivity. Urgency is the important symptoms of overactive bladder as well as DO, detrusor overactivity. Now, here all your answer come cuff associated detrusor overactivity. Onset of detrusor overactivity immediately following cuff pressure peak, then detrusor overactivities. This is cuff associated detrusor overactivity. So whenever detrusor is rising with cuff, it is not stress urinary incontinence. It is cuff associated detrusor overactivity. That's why to make the diagnosis of stress, there shouldn't be any detrusor contraction. If all three are rising, it is detrusor overactivity. This is all bladder compliance we have understood. So this is all about that bladder compliance, that it changes in the pressure with change in the volume of the bladder. Now, key factor, again here you will see, again, all of you who are getting confused with the stress urinary incontinence, you have to understand there will be leak with provocation, means with cuff, with no rise in P det. Then only it is stress. Clear? Now it is clear to all of you. It is clearly written in the talk that leak with provocation, but no rise in P det. Because if there is rise in P det, then it becomes cuff associated detrusor overactivity. So whenever you are doing the urodynamics, you have to check that all your calibration are correct. While cuffing, you are only rising the abdominal and vesical, and P det is not rising, means your catheter in place and measuring the pressure. You will check for filling and storage phase, and then you will check for the voiding. P det, whenever you will get more than 15, it is detrusor overactivity. See, after calibration, they are telling you to check the P det, because P det is your deciding factor. If it is there, it is always DO. If it is not there, it could be stress. So P det is your deciding factor for diagnosis. It could be provoked, unprovoked. It could be with or without urgency and incontinence. Am I clear about now the DO and how you will choose provoked, unprovoked, with or without incontinence, and how you will choose stress only when there is no rise in P det? I think almost 10 times I must have repeated it by now, because I just want to drill it in your mind and you will never get confused with this. Okay, thank you, dear Sadaf. So, thank you, dear Sanya. So, all of you understood it now. Now, capacity, we know 400 to 600 is our normal capacity. Voiding phase, we know how much you will see, how you will interpret. This is our voiding graph. We already saw this, how it looks in the Systometry. You will look for the Vmax, you will look for the pattern of void, which should be bell-shaped. What should be the Qmax normal? Can anybody tell me till what level of Qmax you will tell it is normal?
Up to 36.
20 to
20 to
36.
36. Very good. So up to 36, you will take Qmax normal. So now, when you will see this, you will not panic. What is it? How to interpret? Here is the ml per second. It is Qmax. This is the volume of urine passed. So now you know how to read. And this is while voiding. This is the void. During voiding, you want the P-Ves and P detrusor to rise. So it is rising. And you want the pressure of detrusor how much while voiding? How much should be the P det while voiding? Anybody?
50 cent.
Less than 15.
15.
Less than 15 while filling. Okay, right, but that is for filling. What about voiding? How much I should expect here?
5 to
While
15.
voiding?
What? 70 centimeter.
Less than 70, not 70. Less than 70. So 70 is also abnormal, more than 70 is also abnormal. So anything less than 70, here if you see the pressure, it is going less than 45. So you're happy. It is less than 70, so it is normal. And here you want it less than 15. And here if you see it is going beyond 23, so it is more than 15. Beyond 23 means it is going more than 15, it is abnormal. And here it is less than 70, so it is normal. Clear? Clear about detrusor pressure while filling and voiding?
Yeah.
Yes.
Now I will ask you again, what is first desire normal?
150 to 200
Very good. What will be
ml.
the maximum capacity, maximum systometric capacity, MCC?
400 to 600.
500.
Very good.
500.
500 will be the average. You are correct, my dear. But if they give you 400, you will take it normal. You will not take it abnormal. So 400 to 600 is normal. Anything less than 400 means you will think what? Less than 400 capacity of bladder. What you will
Low,
think? What could be?
Low
low
compliance.
compliance bladder.
No, my dear. No, compliance is by change of pressure with the volume. So you cannot judge only by volume. What about the volume?
Contracted bladder, ma'am.
Low
Yes.
capacity.
You
Contracted
cannot
bladder,
tell it
ma'am.
low capacity bladder. If they give you low maximum capacity means if she's passing the urine before reaching the maximum capacity means her detrusor is overactive. Her detrusor is getting active before the maximum capacity. So that is
Overactive bladder, maybe.
pardon.
If it is capacity is low and it's emptying over, bladder, it is emptying quickly like that.
Yes, yes. If she is not going till maximum bladder capacity, if her capacity is showing low, it is an indication that her bladder is active, overactive. The same way, if the first desire is less than 150, it is an indication that her bladder is overactive. Because you wanted the bladder to go quietly till 400 and her bladder is not quiet. Her bladder is trying to empty before 350, before 380, before 400. These are all abnormal values. If her capacity is 200, that means her bladder is overactive. If her first desire is 100, that means her bladder is unnecessarily contracting before 400, which is our normal value. Am I clear how these two things come in question? So whenever less capacity, whenever less for first desire, think always about overactive bladder. Think always about detrusor overactivity. This is the significance of these two values. Now you know the pressure less than 15 while filling and less than 70 while voiding is normal. Now you know the Qmax 20 to 36 is normal, but at least it should be more than 15, which is your goal. The value at least should be 200 to interpret the normal values. This all application will come in question. So I want you all to remember this so that you can do the questions right. I have more than 15 questions for you all. I collected from all possible sources and recalls to practice it today so that in exam you can solve all the urodynamic question with great confidence without any doubt. So we saw all this, how you will interpret the urodynamics. Now, again, overactive bladder is a clinical thing. Detrusor overactivity is a urodynamic thing, which could be provoked and unprovoked. Stress urinary incontinence, clinical thing. Urodynamic stress incontinence is urodynamic thing. When See, in question, they will give you, she's leaking while coughing. Then you did urodynamics you did, and you didn't find any leak on cuff. What will be your diagnosis?
Stress incontinence.
Stress urinary incontinence. But urodynamics is not supporting. So you will not label it urodynamic stress incontinence. You will label it stress urinary incontinence. In the same scenario, if they give you, in urodynamics, you found stress incontinence, what will be your diagnosis?
Urodynamic stress incontinence.
Yes.
Urodynamic.
In that
Urodynamic
situation, you will not choose now the clinical diagnosis. You will not choose SUI. Now you will choose urodynamic stress incontinence because you have confirmed it with the urodynamics. So now your diagnosis become urodynamic stress incontinence. This is very important point because in exam they give you an option both. So you should know when to choose this and when to choose this. This is a symptom while this is a diagnosis by urodynamic. The same way, if they give you in question urgency and frequency, what you will choose?
Overactive bladder.
Simple OAB.
Very good. But if they give you in urodynamics, you found detrusor pressure more than 20 while filling, what you will choose? How much should be the detrusor pressure
Detrusor
while filling?
Overactive.
Choose overactivity.
Yes. So how much should be the detrusor pressure while filling?
Less than 15.
Very good. And how much it should be while voiding?
Less than 70.
Less than 70.
Less than 70.
Very good. So if you find it more than 70, what is your diagnosis?
Maybe something like that. Obstruction.
Obstruction. Anything obstructing, either
Obstruction.
a stricture, prolapse, anything kinking or obstructing the urethra can lead to more pressure in the detrusor. So this is how you will diagnose and choose your options in the exam. Now, whenever your urodynamic study is not giving you any conclusion, what is your diagnosis? You didn't get anything, you didn't get this, you didn't get this, you have no answers, what you will do? So these are your further tests, which NICE recommend only video systometry and ambulatory urodynamics. So in exam, you will choose one of this. You will not choose PAT test, you will not choose pressure profile because these are advanced tests and they are not expecting you to choose this because this is not of your level, this is not part of your curriculum. So you will choose one of these. If they say that urodynamic study you have done and you didn't find any conclusion out of it. Clear, all of you? So this is all about urodynamics,
Yes.
and now you will be solving all the SB and EMQs of urodynamics. And I want you all to retain all the pressure and measurement so that you can interpret it in the question. So let us take a break so I understand how much you are remembering, and we will go through the upcoming courses of MMRCOG. Before going to this, we will just see what I have for July and Jan batches. So for Jan 2022, many of my students as well as the friends are requesting me to give them this. They are finding it difficult for teaching, for consent, for clinical governance and biostatistics. If you see in July exam, almost 10 to 12 questions from biostatistics. Consent is always their favorite, teaching is always their favorite. And if you do it well, definitely it is like maths. If you know it well, you can do it always correct. There is no confusion. So it is a mathematical calculation. So I thought of coming up with this. So if you want to take all these module to get excellence in this module, you can opt it for $59 and first 5 candidate can opt it for $1. All Jan candidates, if you find it difficult, if you need help in this, I'm there to help. For July already, I have announced the course. It is a long course, 7-month course, starting from 12th of December. The fee was 500, but now it has been reduced to 350. So it is a big discount. It includes 2 courses, regular course plus crash course. Because at the end, you panic. At the end, you want a rapid revision, a crash revision, so that you get satisfaction, you feel confident in yourself. That's why I come up with this plan of 7 months where you get everything in one go. So it is starting in 1 week. It's starting from 12th of December. So if you have decided about giving the exam, don't think about yes, maybe, and no. You start your preparation and decide if you need help, you should take the help. Now, what is the difference between self-study and group study? There is a major difference because it is a long journey. You have to be motivated for a longer time. So doing it by yourself with all the challenges, with all the commitment is difficult. So you need help. You need a group to study, which can hold your hand. All can hold hands and go together. The group can help you in your weak time, and you can help the group in their weak time. So this is how it goes. Go hand in hand. So group study is something what you need always for this difficult and challenging exam. And with the course, you get the group. With the course, you get the mentor, which will give you direct interaction, revisions, timetable and study plan, updates, trends, latest trend, what are the changes, how the exam question are changing, and high quality study material. So it definitely makes a difference in your success. Now, there are myths. I'll tell you my story also. There are myths that you cannot clear MRCOG in first attempt. When I came to Saudi Arabia, I remember very well, I decided to give MRCOG. And my colleague told me, nobody cleared this exam in first attempt. I thought, okay, till now I don't have any record of repeat attempts. But yes, if this exam needs this, let me give my 100% and see. And believe me, I cleared all my exams in first attempt in less than 2 year time. All the parts of MRCOG. First attempt is the best attempt, and all can succeed in first attempt if they do it in a right way and if they get the right guidance, they are giving their 100%, all their hard work, they can definitely clear it in first attempt. Success stories are there with first attempt. Only thing is you have to give your 100%. I also took the course to keep myself motivating, to keep a pace, because at the end, I don't want to lose the battle before fighting. Because most of the time, the reason of losing the exam is you panic in the last moment. You panic 1 month, 2 months before the exam. That is the time you need the most the mentor, your group, to keep calm. To keep calm so that you have confidence and then you can succeed. So if you believe it, you can achieve it. Definitely. Now, the students who couldn't succeed in first attempt, don't get disheartened because, as I always tell, success stories are different and unique. So don't judge yourself. You might be sailing a different boat. The other person who succeeded in first attempt might have no commitment, might be they have a different story. Don't judge yourself on the basis of failure because failure is an attempt for success. So definitely you have to change your strategy. Many of my students and friends, they told me that they are failing always with 3 to 4%. Why it is so? That means you have not changed your strategy. That means you just hide behind the curtain. Why? Come out, talk to your friends, talk to the mentors. What is your weaknesses? Why you think you couldn't do it? How you can do it differently this time? What went wrong? If you don't discuss, if you hide from the scene, nobody can help you. So please come forward and take help if you need. And I'm always there to help you. Especially my heart goes for the students who couldn't do it in first attempt. So don't feel disheartened. There are people here to help you. Take help if you feel you need help. How course help you? I will tell you the important aspect how course help you. First of all, you will get the schedule. You will get monthly schedule, you will get daily schedule. So you are organized. You are starting in an organized way. You get the notes. Notes making most difficult part. I took 3 reading before making notes because you cannot make notes in 1 reading. You don't understand what to write. You write everything. And it is not a notes. It is writing the guideline in the piece of paper. So you need to understand how to make notes, what is important, what is not important, what is to memorize, what is asked in question. So by course, you get an idea easily. You don't have to search in the guideline what is important, what not, because we are giving you the summary. We are giving you the notes. My notes become your notes now in the lectures. So the notes making headache is gone now because you are part of course and the mentor is making notes for you. Only you have to memorize. You get the material in advance 1 week prior to the live class. So you can prepare yourself for the live class so that you will understand well in the class and retain well in the class itself. Always after my class, students are well versed, at least with 10-20 points they can remember. It's not like they have listened to the lecture and they didn't get anything. They didn't grab anything. No. They can memorize things because that is how the effective learning works. If you do effective lecture, like now, we have learned the urodynamics. Now you will memorize some things. You will not forget it. You will listen to the recording in YouTube later, but you will definitely get something from this lecture today, and your take home message will always be with you. There will be group study. I cannot emphasize it enough because as you see in the teaching method, group discussion help in 50% retention. While if you read it on your own, it's only 10 to 20%. So group study is very, very important for this tough exam. Please open up, please discuss in the group. Don't feel shy. Nobody is here to judge you. Everybody is sailing through the same boat. I have also sailed through the same boat. I have also faced the same difficulty you are facing now. The benefit, of course, is revision at your convenience. You have the recording, you can listen to it anytime and revise the module. You can listen to it 10 times if you want. You can listen to it 2 times and you have done 2 revision. If you listen to it 3 times, you have done 3 revision of the module. So it's at your hand, at your convenience. You can revise as much as you want. Like the course students in the end month, when they feel low, when they feel they're losing it, they listen to the recording. So they are not wasting time and their one revision of one module is finished in 5 to 6 hours. What else you need? You can do revision very quickly and the right points you are revising, which you have already understood well. Balance of reading and question solving is very important. Some of the students will only read and don't do question. Some will only do the question and don't do reading. First of all, you have the concept. For that, you have to read. If you read, if you do it in an organized way, then only you have the concept to solve the question. But if you don't solve the question, how you will understand how the sentences which are given in the guideline are putting in the question. So both things are equally important. If you focus on one aspect and losing on another aspect, it's difficult to succeed. It's borderline. That is the reason of 2 to 3%, 4 to 5% always lacking because you are not keeping a balance. Question and answer sessions. When we take the session, we have the question and answer sessions also. The students read. Even the shy student also will read the question. Even the shy student also will open up. That's why we do small group study. Everybody get chance to read the question and learn how question reading is the most beautiful art to solve the right answer, to give the right answer. So that is the part of the sessions, the question answer sessions. Mock exams are there for your assessment so that you can understand if you are not performing well in mock means you need another revision. You need another listening to the session. So that give you your assessment that how much you are scoring mock, how much you are prepared, and how much more time you have to listen to the lecture. So all these features you get with the course, which help in your final preparation and your exam success. So this is my course feature. If you see, it's a 7-month course, regular plus crash course. It is having 41 sessions, 3 to 4 hour duration, includes the question and answer solving, all the targeted points, mocks. There will be separate classes for genetics, CTG, consent, biostatistics, contraception, and urodynamics. The most difficult portion you feel will be sorted out in your mind. There will be revision sessions, there will be flashcard, there will be EMQ discussion in the study group. All this will help you in acing the first attempt. And definitely, your success is confirmed if you are giving your hard work with the right guidance. So why to choose MMRCOG? Because your success is our goal. This is the sessions. If you see 41 sessions, and if you see the revision, 3 revision will be finishing in the May, and 4th and final revision by the crash course. If you have done 4 revision, believe me, if you have given your 100% in this, nobody can stop you from passing the exam. These are my some students review, which is very near to my heart, of some of the September batch and some of the Jan students review. Why us? Why MMRCOG? Why? How it is different? It gives you small group teaching, very important for this high competitive exam, which you have taken the challenge to do. So small group teaching gives the shy student to open up, and every student matter for us. So small group teaching is something which you need for this difficult exam. Quality material in a simplified way. If you see my slides, I never give you complicated charts. Even my flow diagrams will be hardly having 2-3 threads, not more than that. So if you see it's simple way, then only you can memorize, you can easily read it. But if I give you a long chart like it is given in the guideline, you will not remember anything ultimately. Then why not read from the guideline? So I always try to make it simplified. If you see in my YouTube lectures also, if you see how my slides are, it is always simple. It is not a complicated chart or graph. It is always in a simple form, only little information at a time, so that you feel like seeing it again. You don't feel nauseating when you see a long chart, long thing, which you cannot understand, which you feel is very complicated to read under exam pressure. So this is how a quality material in simplified way help you in quick revision at a glance. If you see my students, they all have my WhatsApp number. They communicate with me in that, not only to ask their doubts, but sometimes if they are feeling low, if they are feeling exhausted, burnt out, they will message me, madam, I'm feeling really low today. I'm feeling I'm losing it. And a single word of encouragement and moral support will bring them back to the track. So somebody is there to hold your hand in the dull time. Because definitely you will panic before the exam. 1 month before exam, all are going to panic because it is vast ocean of the knowledge. If you don't do right prioritization, very difficult to read and finish your revision, especially the dogs. Dogs are something which are really bothersome for the students. As well as you get 24/7 assistance. As I told you, always I am there for the students available, and always I troubleshoot their problem. If some of my students are there in the group today session, can you tell me, are you feeling happy with the course? Are you feeling satisfied with the course? My teaching, how do you want to rate it? Any of my student, if they're in the session today, can comment.
Well, I feel satisfied, very satisfied. And I was one of those students who've taken the exam before coming to this study group. In everything that Dr. Shweta has placed in this bit right here is actually true. I certainly feel that I have improved in my study habits and my understanding of the material. I feel like I can, contact her if there are any issues. And working in a small group of individuals certainly helps as well.
Thank you. Thank you, Dr. Giovanni. Thank you so much. Thank you, Dr. Zahra. Thank you so much.
I am
Really
also want to
Yes.
thanks to Dr. Shweta. I am also your student, and I feel very satisfied. Before this course, I was always I used to think I am unable to attend this exam. I can't do anything. I can't attempt MRCOG 2, but now I'm very relaxed, very satisfied. I can do it, inshallah.
Hopefully, yes. Inshallah, all of
Yeah,
you are trying.
even thank you from me also. It's been really nice to go through this journey. Many facts have been cleared and very easy to approach you. and our doubts are cleared. I mean, I think you are faster in seeing our problems than we see back the answers. So it's really, yeah, and it's very, in a very simplified way, you are able to, you put the things across to us that we are even able to attempt the questions that you ask us after at the end of the class. So it's been very, very helpful, and hope we all succeed in it
Yes,
at the
definitely.
end
You
of
all will
all your
succeed.
troubles.
And everybody attending the session today, I wish them luck that they will all succeed. And definitely, if you all are saying
Thank
that
you
I'm
so much.
prompt enough, believe me, I am restless enough. I am restless enough to answer the question whenever you put it down, rather than you knowing the answer. Dr. Kopa mentioned it very correctly. Even even my family will see that I'm so restless. If I see any question in the groups, I just want to answer it as quickly as possible once I have seen it. So that I really feel that the students should get their reply as soon as possible to feel relief from their doubt. Thank you so much for the beautiful reviews and really made my day, and I'm really overwhelmed with the responses. If you see the course fee, it is $500, but as I told you, early bird discount is 60/50 till 10th of December. You can pay in the installment, and there are group discounts also for group of two, 300 each, and three or more, 250 each. If you see, it is for 7 months, so effectively it is $50 per month. So it's quite reasonable and most worthy of all. And this is my course plan.
Hi, Dr. Shweta.
Yes, my dear.
Hi, Dr. Shweta.
I cannot hear you. Can you speak a little loudly?
Yes, hi, Dr. Shweta.
Hello, my dear. Yes, tell me.
Sorry, I had to leave the class at the middle of the lecture because I had a surgery.
No
I
problem.
actually want to say thank you to you for everything. You have really made this reading very, very easy for us.
Thank you.
And you had summarized all the guidelines. We are doing her course, and we are
Thank you
really,
so
really
much.
enjoying it. We started after a very long time. We started around August, and we have been with her. So I would really, really recommend this course for all of you. Thank you.
Thank you so
Thank you
much.
so much,
Thank you
Ma.
so much. So there are special offers for students who couldn't pass in September
Dr.
because my
Shweta.
heart goes for them. Who didn't get exam booking in Jan because you were preparing and you didn't get the booking. Now you have to take it further longer till July. So definitely you feel frustrated. You lose a track. So you need some group to keep motivating you to make the journey more pleasurable actually. It's more easy and more pleasurable. You learn and you happy with learning. You are not stressed while learning if you are doing it in a right way. If you are not in a job, you are facing a financial crisis or anything, you can always contact me. And it is not to make money. The course is to help the students. If you have any issues, if you want to join me, you are more than welcome, and never think about any hindrance which is stopping you from learning, because learning is by giving. So let us start the question answer sessions. Now my time of speaking is over. Now this is what we do in the sessions also. First I speak and then the students speak. So let us go with the quiz. Yes, anybody can read it. The first question.
What do lower urinary tract symptoms consist of? The LUTs.
Yes.
It consists of
Yes.
storage symptoms, avoiding symptoms, and
Yes.
post-voiding symptoms.
Yes. Very good, Dr. Gopa. So this is three things the LUTs consist of. So all this urge incontinence, stress urinary incontinence, this is part of what according to you?
Storage
Very good.
problems.
Very good. Now, how common are this in general population?
It's about 36 to 67%.
Very good. Very good. So up to 2/3. Remember it like that. Up to 2/3.
Up to 2/3.
Yes.
Mhm.
Then what are the most frequent? What is the most frequent LUT? Is it storage, it is voiding, or is it post-micturition?
Storage.
Storage. Very good. So most frequent is storage. What is the most common type of incontinence? Stress, mixed,
Stress.
or urge? Stress. Very good. So see
Stress.
how you can understand all the things, all the incidents now in your mind, that what is asked in your exam. Very good, Dr. Krupa. Now next, this is the SBA. Yes, Dr. Giovanni, can you please read it?
Okay, a 50-year-old woman presents with urinary incontinence, frequency more than 10 times during the day and 2 to 3 times at night. She has no urge or stress urinary incontinence. Her filling cystometry trace is showing below. What is the most likely diagnosis? So, P vesicular, there's no difference between the P vesicular and the detrusor. I'm looking at the detrusor first.
Very good. Very good.
There's no, they specifically ask about the filling cystometry. So that's going to be the first half
Yes.
of the diagram.
Mention in the exam, like here filling and here voiding. If you see up till here it is filling and then this is the voiding. So we are focusing on this part because this is whole filling, because they have not mentioned differently filling and voiding. This is filling cystometry, the whole thing. Now you will judge it first by detrusor. Now next.
Yes. So there is no detrusor. Sorry, let's see. So looking at the options, it would be urodynamic stress, urinary incontinence. I don't think that's not the answer because there is detrusor activity. Very good. Yeah. Mixed urinary incontinence is not it. Yes. Detrusor overactivity with incontinence. Yes. There is no, I don't see any incontinence here, so that's not it. Very so good. It's probably just detrusor overactivity, D. Detrusor overactivity. Now I will tell you why I have put this graph, because you have to understand the small things. Oh yeah, I didn't see that. There's there is a small leak. So that's leak then, a leak.
Yes, very good.
So
what is your answer now?
So this is detrusor overactivity with incontinence.
Very good. How clear it is now? First you have to see the P det. If there is P det, automatically your all stress mixed is out. Now you have to see the overactivity. Now the small things you have to notice. You have to understand in exam also the small things, because the volume will be very small of leak. So you have to notice the small eruptions. If you miss it, you will make the answer wrong. So your answer is very correct, Dr. Giovanni. It is detrusor overactivity with incontinence. E is D.
Yes.
Sorry.
Dr. Shweta, what is this blue thing at the end? This blue up and down like that?
This one? This is just the trace.
Yeah.
You don't have to go into this. This is error. It actually shouldn't be. I'm sorry. This is, I think I have taken it. This is detrusor overactivity with incontinence. I think I have erased one option. So it became like this.
Okay.
So the answer is C.
Okay. So it will not be there in the graph, no?
Yes.
That's it.
Now, yes, next who will read? Dr. Fatima. Dr. Fatima, you're there? Okay, next, Dr. Aminat. Dr. Aminat, you are there? No, okay. Dr. Shazia? Yes, Dr. Aminat. Yes, go ahead. Your voice is little low. If you can make it little more.
A 50-year-old woman sent to urinary.
I think your voice is not clear, my dear. We cannot hear you.
Hello.
Yes.
Hello, ma'am. Can I read?
Dr. Aminath, we cannot hear you, unfortunately. So maybe with a strong connection, we will listen. You can attempt another question. Yes, my dear, you can read. Who is this?
I am Dr. Fatima. Hello.
Yes, Dr. Fatima, read.
Yeah. A 50-year-old woman present with urinary leakage on cuff, urinary urgency frequency more than 6 to 8 times during the day and 2 to 3 times at night. Her urodynamic trace is showing below. What is the most likely diagnosis?
Yes.
So first I will see P. detrusor.
Very good.
There is a, yeah, with cough there is increase in the detrusor contractility and also vesical and abdominal pressure also increasing. So the answer is cough provoked detrusor overactivity, E.
Okay. Do you think it is correct? Do you think that how you calculate the P det? It is vesical minus abdominal. If you see this graph, this is the difference.
Yeah.
This is little higher
Yes.
than the abdominal, and this is the difference.
Abdominal,
This
yes.
is not detrusor
Yeah.
overactivity. The detrusor is normal. The detrusor is not contracting. You get my point? The P ves
Yeah.
and P abdomen difference is little this erase, little this
Okay.
peak is because of the difference. But if you get detrusor overactivity, you should get really a detrusor overactivity. This is just the difference.
Okay.
According to me, this graph is straight. There is no activity in the detrusor. That's why I put the most confusing one so that in exam you don't get confused. Right? So this is the
Okay.
difference.
Yeah.
If you see, this is little bigger than this one. And this is the difference. So
Yeah.
this is not detrusor activity. This is no detrusor activity. Okay? And if you see,
Yeah.
this is a
Detrusor is
leak point.
normal.
This is a leak point. This is a leak point.
Yeah.
So now, what is your answer? And this is a voiding. Okay? This is the voiding. Voided volume. Whenever you see voided volume, flow rate, these all are the voiding part. So ignore this. You have to
Yeah.
judge the filling one. So, okay, tell me, what is your diagnosis now?
A. Urodynamic stress urinary incontinence.
Very good, my dear. So as I told you, see detrusor first, and if detrusor no activity and these two activity, you got your diagnosis. Urodynamic stress
Yeah.
incontinence. So that is how you will interpret. Please don't confuse with the small changes. Like in this, the previous slide also, the previous slide, if you see, this one also, the small leak you shouldn't ignore. The small leak you shouldn't ignore. This is very important to make the diagnosis. Now, yes, who will read the next? Yes, Dr. Bridget, are you there?
May I read that?
Yeah, go ahead. Who is this?
Sania.
Yes, Sanya, go ahead, my dear.
You are teaching medical students about urodynamic studies, and they are confused about the pressure detrusor, how the pressure detrusor has been calculated.
Yes.
And it is actually the pressure vesicle minus pressure abdomen.
Very good. So what is your answer?
It is subtracting vagina, so it is urodynamic. So the A option is urodynamic equipment calculates P detrusor directly. The B is urodynamic equipment calculates the detrusor by subtracting abdomen from pelvis. Yes, it's B.
Very good. So now when you're clear, you don't have to read the another option, but in exam, don't do this. In exam, always read all the options. But when you're clear in your mind, don't get confused also. If you are clear, then this is your answer clear cut. My special request to all of you, don't change your answers by thinking again and again. Whatever comes first in your mind, that is always the right answer, and that is what from your brain. It is not from the last
Dr.
minute
Shweta,
study. Yes.
sorry to interrupt. Is
No.
it B or D? Is it P vesicular from P abdominal or P abdominal from vesicular?
It is
Shouldn't
D.
it be D?
P
You have to
abdominal from
get
P
the
vesicle.
abdominal from the vesicle. Vesicle is the bigger one.
It's B.
So you have
Okay.
to subtract abdomen from vesicle, then you get your detrusor. So the biggest pressure
Okay.
is vesicle. If you see in the last slide, just a minute, I'll show you this. If you see here, this difference is coming because P vest is bigger than abdomen. So vest is always bigger than the abdomen. So you have to calculate the P detrusor by subtracting abdomen from the vesicle. So I know it is little looking strange to us, but remember like this, that vesicle is always biggest. Bladder is always biggest. BB, bladder biggest. So you will not get confused later. Because in exam pressure, even simple thing look confusing. Always try to memorize it in simplified way, like alphabetically or some other way, so that you will not confuse. So bladder biggest. Clear?
Yes.
Okay, thank you. Next, who will read this? Question 4. Yes, Dr. Heba, Dr. Shazia, or Dr. Heba? Who is there?
Yes, Dr. Shweta, I will read. I
Yes,
don't know
yes, go
anyway.
ahead.
Okay. A 51-year-old woman has had urodynamic studies done because of multiple lower urinary tract symptoms. The result shows the following. During the filling phase, maximum bladder capacity of 460 ml. Per vesical pressure and per abdominal pressure increased synchronously when the patient was asked to cough. Pressure detrusor fluctuated between +5 and -5 centimeter of water. During the boiling phase, the patient leaked on coughing and PET is what? Fresh.
Sorry, P det. This is P detrusor.
Pressure detrusor was +5 cm of water. Which of the following options most likely the diagnosis? The
Wait.
patient leaked during the boiling phase. The patient, yeah.
Yes. Now, Dr. Shazia, you tell me, what is your interpretation from the question? Is this capacity normal? Is these pressures are normal, or you feel it is abnormal?
Yes, bladder capacity is normal. It is almost any 400 to 600 ml, 460.
Very
It's
good.
okay during the filling phase. Then pressure vesicle and abdomen increase synchronously. Both are increasing when patient asks to cough. They can be increased also. The coughing, the pressure increase. Then pressure detrusor fluctuated between +5 and -5 cm. So pressure detrusor is in the filling phase. It is about 15 less than 15 centimeters. So it is also +5 and -5 cm. So it is
normal.
also okay.
Very good. Yes.
Normal. Okay. In the voiding phase, patient leaked on coughing.
Yes.
Voiding phase, and the patient detrusor was +5 cm water.
Yes.
So voiding phase, patient pressure is less. Its pressure should be less than 70 cm. It is +5 cm. So it is also, but
it is normal. Less than 50 is
on
normal.
coughing it's leaking.
Yes.
It's normal.
But she is leaking.
Which of the following option is most likely?
What do you think?
So stress incontinence, I think she. So it is urodynamic stress incontinence.
Very good, my dear. So see how easy it is, because they have again and again mentioned to you detrusor is normal, detrusor is normal. So there is no detrusor. So forget about this, forget about this. No mixed, because detrusor is normal. No normal, because there is leak. So the answer is urodynamic. So Dr. Shazia, do you think after attending the lecture it is easier for you?
Yes, it is understandable. Good.
Is the answer E. Next, who will read it? Dr. Heba?
Yes.
Dr. Heba, you are there? Okay, Dr. Umehani? Okay, Dr. Rehana?
Yes, Dr. Shilpa.
Yes, go ahead.
Okay. You see a 62-year-old woman in your gynecology clinic. She presents with urgency, daytime frequency, nocturia, and urge leakage. What is your initial step in the management?
Yes.
Ultrasound examination of pelvis,
Wait.
frequency, volume
Wait, Dr.
chart,
Rehana.
urodynamics, cystoscopy,
Wait,
and
Dr. Rehana. Wait.
the last is yes.
Dr.
Yes.
Rehana, whenever you read the question, first think what question is asking, what is your answer in your mind. So what do you think? Whenever a woman present with lower urinary tract symptom, what is your initial step? What is the first step?
Initial step.
Diary, urine frequency volume chart.
And
Will
before
make
that?
diary, no?
Before that?
It's urine DR to rule out urinary tract infection.
Very
Then
good.
urinary diary.
Very good. So first of all, if they ask you, see here, there is no urine analysis, but if it is there, urine dipstick or urine analysis,
yes,
you will first choose that.
It should be the first one.
So
Yeah.
you should have clarity in your mind because question will be made in different forms, but you should have clarity first, second, third.
Yeah.
So first thing, urinary analysis, urine analysis or dipstick, whatever. Second thing will be diary, and third thing will be urodynamics. So definitely they will not
Urodynamics.
ask you urodynamics in the step because it will be after the conservative measures, before the surgery. So they will either ask you urine analysis or they will ask you diary. Okay, now read the options and tell me what is correct.
B.
Ultrasound examination of pelvis. This is not the first option,
Very
definitely.
good.
Frequency volume chart.
Yes, very good. What do you think? Frequency volume chart is another name of diary, right? Frequency volume
B is
chart
the
is
answer.
another name of
Yes.
bladder diary.
So
So
this is the answer. Yes.
definitely you will choose.
Okay, this is the answer. Okay,
I
then.
put this because sometimes we will get confused with the name. Frequency volume chart is diary only.
Okay.
And definitely urodynamic cystoscopy Q-tip test anyway is not recommended, so forget about it. Cystoscopy you will not going to do. This is an advanced test done by the urologist or urogynecologist. Urodynamics is not your initial step. Ultrasound not your initial step because we know urine analysis and bladder diary. So answer here is B.
Okay.
Very good.
This is
So this is how you have to first think before reading the option. Don't read the option clueless. Otherwise,
Yes.
you will think everything is correct and you will get
Okay.
confused. First, take a minute to think what you got
Yes,
from the
thank you.
question and what is in your mind. Then try to look for it in the option. Okay, now next, who is there? Who wants to read? Yes, Dr. Gopa, can you go ahead?
A 50-year-old woman presents with urinary leakage on cuff. Urinary urgency frequency more than 6 to 8 times during the day and 2 to 3 times at night. Her urodynamic stress is shown below. Okay. So what is the diagnosis? Okay. So PDEX is PDET. This is the green one, no? It's written minus 11.
Yes, this is
PDET.
Yes, green one.
Okay. Yeah. So that one, what IDC with leak. What is IDC?
This is idiopathic
Cuff
detrusor
with
contraction.
leak.
Idiopathic detrusor contraction.
Idiopathic.
And this is cuff with leak.
With leak. Then cuff with leak, and then again idiopathic detrusor contraction with leak.
Here,
So detrusor has contracted.
I will just show you here. See, here it is still significant, but here it is, see how much small amount leak. So this small raise in the flow also, in the volume also is significant. So never miss this small finding. So what is your diagnosis, Dr. Gopa?
This looks like detrusor overactivity provoked with leak.
Okay. So this is detrusor overactivity with the leak. Yes, you're right. And what about this cuff with leak and no detrusor overactivity here?
Cuff with leak. So that is stress.
Yes. So what
But
will
that
be
is
your
in the,
diagnosis?
yeah, mixed.
Mixed. Yes. So usually they will not give you all this written. I have just put it so that sometimes they will make the graph like this. So you have to understand that cuff with leak and without detrusor contraction or idiopathic detrusor contraction with leak, if both the things are given, you will make the diagnosis of mixed. Okay, next question. Who will read? Anybody who is interested in
Thank you.
reading can open their mic and read.
I'll read if
Okay,
nobody
go
is
ahead.
ready. You see a 52-year-old woman in your urodynamic clinic. The uroflowmetric curve is bell-shaped with a maximum flow rate of Qmax of 23 milliliters per second. The post-void urine is 50 ml and multi-channel systometry shows involuntary detrusor contractions during the filling phase, which are provoked by the sound of running tap water. The maximum systometric capacity is 450 ml. What is the most appropriate diagnosis?
Yes.
Okay, so the uroflowmetric curve is bell-shaped. It is normal. Qmax is normal. Post-void urine is normal. Then the systometry shows involuntary detrusor contraction during the filling phase.
Yes.
So there is detrusor overactivity there,
Yes.
which are provoked by the sound of running tap water.
Yes.
The maximum systometric capacity is also normal.
Very good. Yes. So what is
450,
the answer?
400 to 600. Detrusor overactivity.
Yes. So choose the answer.
Normal bladder capacity, detrusor overactivity, and no voiding dysfunction. Normal bladder capacity, detrusor voiding dysfunction. I think the first one.
Yes, good. The first one. Now B you have ruled out. Read the third one. C, the reduced capacity. So you already made it normal. So this is out. Reduced capacity out. Normal is out because there is provoked detrusor overactivity. So your
Detrusor
answer is
overactive.
what?
Yeah.
It's A.
Yeah.
So if you remember the normal
Yes.
value, you can make your answer. If you don't remember the normal value, you cannot make your answer. So key is A. Very good. Yes. Now this EMQ. We'll start from the beginning. Yes, Dr. Giovanni, can you read?
Okay. So question 1 says, a 55-year-old woman having LUTS on urodynamics, her first desire to void is 90 mils, bladder capacity of 200 mils, detrusor pressure while filling is 30 centimeters of water with flow rate of 20 mil per second and residual volume of 60 mil. Okay.
Yes.
So the first thing is her first desire to pass urine is abnormal. It's 90.
What
and
is
it
the
should
normal
be
value?
between 150.
Very good.
Normal value is
Very good.
150 to 200.
Yes.
Also, her bladder capacity is abnormal
Very good.
because it's less than 400.
Yes.
Her detrusor pressure on filling is more than 15.
Yes.
So that's detrusor overactivity there.
Very good.
And her flow rate she has a flow rate of 20 mils per second. Yeah, so that's okay because I think it's more than 15.
20. Yes, more
And
than
her
20
residual.
is normal and the maximum will be 20 to 36. So 20 is acceptable. Yes.
Yes. And her residual volume is 60. It's less than 100, so it's okay.
Yes.
So here she definitely has detrusor overactivity.
Yes.
So this is looking at the options. A is not, well,
yes.
Overactive bladder is just a symptom, so it can't be that. It's not SUI. It's not urodynamic SUI. It's destrucer overactivity, urodynamic finding on destrucer. That could be a possibility.
Yes.
Cystocele is not the case. Chronic retention is not the case. Diabetic, no history. Erythrostriction, no history. She doesn't have any incontinence, so that rules out destrucer activity with incontinence. There's no stress incontinence, so there's no mixed incontinence. And this is not a provoked destrucer overactivity. So I think it's urodynamic. It's D, I think, D.
Yes, D, detrusor overactivity, urodynamic finding of detrusor overactivity. Very good. So D is your answer for question 1. This is a recall question. So now you got the clarity upon that. Now second question, who will read? Dr. Fatima?
Excuse me, Dr. Shweta.
Yes, my dear.
In question number 1, why not unprovoked detrusor overactivity?
Yes, that is also a possibility.
It could be.
It could be a possibility, but this is a recall question, so we don't know what thread is missing. So usually, if they are giving you unprovoked detrusor overactivity, they will not give you DO, because DO, if not mentioned provoked, it is unprovoked only. This D and L are same.
Yes, ma'am.
So because it is a recall question, as I always say, that the question as well as the options are not accurate. But you understood the concept. Either it is DO or unprovoked DO. It is same. It depends on what is given in the question.
Okay, thanks.
Okay, next. Who will read the next question? Yes, Dr. Fatma.
Yeah, I will read. A 45-year-old woman present with urge incontinence. Urodynamics show first desire to void at 100 ml. Detrusor pressure during filling 20 centimeter of water with urgency and leak. Bladder capacity 250 ml. Flow rate 25 ml per second. Residual volume 50 ml. On cuffing, there was leak of urine.
Yes, so what do you think?
There was incontinence. Urodynamics show first desire to void at 100. This is less. It should be 150 or more. Detrusor pressure during filling 20 centimeter. It should be less than 15 ml.
Yes.
So it's more pressure. So might be detrusor overactivity.
Yes.
With urgency and leak. Bladder capacity 250. It should be 400 to 600. It's low. Flow rate 25. It's normal. Residual volume is 50. It's okay. On cuffing, there was leak of urine. So I think provoked detrusor overactivity should be the answer.
My dear,
because on cuffing there was leak.
Overactivity, and one is cuffing and leak. As I told you, this is recall. The sentences might not be complete, but they are telling you about detrusor overactivity and leak, and they're telling you about cuffing and leak.
Cuffing
you don't know
also
this
with leak.
while
So
this cuffing there is overactivity or not.
Overactivity or
They
no?
are
Yeah,
telling
yeah.
both
So maybe mixed. Yeah.
Maybe it is a mixed one.
Both.
They are telling one
Yeah,
about
maybe
here.
mixed.
They are not mentioning about detrusor overactivity. So you will assume that there was no overactivity while cuffing. So it suggests stress, and this suggests urge. So combination of it will be
Urge.
mixed.
Mixed.
So
Yeah.
the answer should be J. Yes. Dr. Aminat, can you
Mixed
read now?
incontinence.
Dr. Aminat. I think Dr. Aminat connection is still weak. Dr. Shazia, yes, go ahead.
A 50-year-old woman underwent vaginal hysterectomy for prolapse uterus, complaining of continuous leak of urine. In urodynamic, first desire at 150 ml. So it is normal when the bladder is filling, and bladder capacity is 400 ml. That is also normal with the normal limit. Flow rate and residual urine are normal. So maybe it is fistula, like in the zygovaginal fistula, maybe it is like that, because it is in the bladder area, it is all is okay, because it's first desire is okay, if bladder capacity is okay, flow rate is, everything is okay. But there is continuous leak after hysterectomy, so it's go with the vesicovaginal fistula, I think.
So whenever they want to
okay?
ask you fistula, vesicovaginal fistula, they will give you always continuous leak. Once you see the word continuous leak, think about vesicovaginal fistula. If there is option of uretrovaginal fistula, will you choose that, Dr. Sazia?
If uretrovaginal fistula, then urodynamic study will not be normal. There will be no bladder capacity, will not be good, and this uretrovaginal fistula, because from ureter and vagina, so it is leaking from ureter to the vagina, so there is no bladder capacity will be reduced. It's like that, I think so.
No.
I don't know.
Dr. Shazia, the bladder is normal. Ureter has got connected to the vagina. Bladder is no problem. So if you do the urodynamics for the bladder in a patient with uretrovaginal fistula, it will be normal. Bladder will be perfectly all right because the problem is ureter has got connected to the vagina. So uretrovaginal fistula, you will not have continuous leak.
Okay.
So if whenever they give you continuous
uretrovaginal is the zygovaginal fistula.
So whenever they give you continuous leak,
Uretrovaginal.
Yes.
So continuous leak is the zygovaginal fistula. Uretrovaginal, when on maybe on cuffing, on that, on pressure, it will start leaking like that.
Urine will be draining from the ureter. Ureter is not going to constantly drain the urine, right? If the patient is draining urine, it is not constant.
Yes.
So if they give you continuous leak, they want you to direct to vesicovaginal fistula. So if you see continuous leak in question, directly choose vesicovaginal fistula, because there will be some amount of urine always in the bladder. That's why there is always continuous leak, and the bladder will always be normal in cases of injuries, because bladder is not having problem. Bladder system is all right. Because of your fistula, you are having the leak. Clear?
So what about uretrovaginal fistula? How the question come for that, uretrovaginal fistula?
Till now, they have not given the question because they always want you to understand the vesicovaginal fistula. So if they give you continuously, choose it. Or they will give you some difficult surgery like endometriotic surgery or something, some hint that ureter could be injured.
Okay. Okay. Thank you.
Okay, so this is the right answer. You all did really well. So next, who will read this? Anybody who is interested in reading and not read, open your mic and read it. Dr. Ummehani, Dr. Heba, if your mic is working, you can open it. Or anybody else if interested in reading.
Question number 1. On urodynamics, bladder volume 250 ml, first sensation 100 ml, residual volume 80 ml, peak flow 30 ml per second, detrusor activity with urine leak seen with when provoked with running tap water. What's the diagnosis?
Yes.
Bladder volume is 250 ml, which is reduced. First sensation 100 ml, it's also reduced. And residual volume 80 ml, it's normal. Peak flow is 30 ml, normal. Detrusor activity with urine leak seen when provoked with running tap water means detrusor is overactive. And what's the diagnosis now? It's detrusor overactivity, provoked detrusor overactivity.
Very good. Because they have already given you the work provoked, that it is provoked by running tap water.
Yes,
so it is not emollient really. It is not idiopathic. It is when you run the water, she had the detrusor overactivity. So this is provoked detrusor overactivity. So answer is K.
K.
Yes. Next question.
May I?
Yes, go ahead.
On question number 2, on urodynamics, the bladder volume is 400 ml and the first sensation is 150, that is normal, and the residual volume is 50, that is again normal. Peak flow rate is 30 ml per second, that is normal, and there's no any urinary leak when provoked. What is the diagnosis? It is all normal, so
Very
it's
good.
normal urodynamics.
Very good. So diagnosing normal is a big thing, believe me, because you are constantly thinking about abnormality. So if you see normal, if you really is confident, then only in exam you will choose normal. Otherwise, you will keep finding the problems. So diagnosing it normal is really commendable job. So I'm very happy that you could understand it is normal. Very nice. So normal is right. Next question. Yes, anyone can read it.
I'll read. Mrs. Green's urodynamic results are as follows. She has initial residual volume of 50 ml and first desire to void at 120. Maximum bladder capacity is 380. During the filling phase, systolic detrusor activity is seen. So she has her residual volume is okay, 90 ml, no? Residual volume. So that's below 100. And first desire to void is 120. So that is little less, 150 to 200 it should be. Maximum bladder capacity is also reduced, less than 400. So during the filling phase, systolic detrusor activity is seen. So detrusor overactivity.
Very good. So what is your answer?
Detrusor overactivity. This D?
Very good. So answer is D. And as we discussed earlier, it could be unprovoked detrusor overactivity also. So these two options shouldn't have been there. Either D or L, both are same. So this is detrusor overactivity. So if you see K and L, same what you told. Very good. So you all have done a wonderful job. I think I have also done a wonderful job because you can answer all this difficult question. Believe me, I was always
Yes, it's
confused
a
while
nice
preparing.
answer.
Thank you, Dr. Sania. Thank you so much. So this is my Facebook group, Telegram group where we do daily questions, and this is my YouTube channel where I put the recording. Recently, I put sexual assault. Earlier, I put peripartum cardiomyopathy. So if you want to go ahead, you can go ahead and listen to that. SGA GTG is there, very beautiful guideline. So that kind of help you in your preparation. Anybody has any question regarding urodynamics or anything else?
Dr. Shweta, this compliance I couldn't understand. You told between the compliance, bladder compliance. That was,
Bladder
I don't
compliance
understand.
could be low or high. Low means the bladder is
Low or high.
not distending. Not distending means the bladder is not spreading, so the pressure will rise. So even with 30 ml of water, the pressure is rising to 1 centimeter of water. That is low compliance. Ideally, it should be 1 centimeter should rise with 40 ml. So with 30 ml, if it is going high by 1 centimeter of water, it is low compliance. While in high compliance, it will rise by 1 centimeter by more than 100, which is also abnormal. Ideally, it should rise by 1 centimeter by 40 ml. So if it is not rising by 40 ml and it is going up till 100 and then it is rising, that is high compliance, means bladder is stretching and not rising the pressure. So it is very flexible. So it is high compliance. If it is less flexible, it is low compliance. So that is how the difference of low and high compliance. If they give you that value in exam, they will ask you what could be the reason. So radiotherapy, like post radiotherapy, it will be low compliance. While after neurogenic bladder, like multiple sclerosis, neuropathy, like diabetes or spinal cord injury, nerve injury, it will be high compliance bladder. So that's how the question will be formulated from that.
Okay, thank you.
Okay, so we will wind up the session. Thank you all for attending today and learning with me. Best wishes for your exam. And if you are for July and you are planning to give the exam, you want to learn together, then please join me. And I'm just a call away, just a number message away. Thank you all. So good night. Enjoy your reading.